When it comes to an anesthetic procedure, usually every client that comes in, we will definitely print out a check-in sheet for their patient. So for example, this check-in sheet right here gives all the signalement of the patient. So for example, we have Coco here, who is a spayed female. She's 3 years old, has a patient's ID number. She is a Yorkie mix. Yorkshire Terrier mix is what it's actually under. We have their color, which is brown and black. And then the previous weight that we have in here, which would be 11 pounds here. And any allergies that the pet would have would be listed under here. So no allergies. Any alerts, so for example, if they had a reaction to a previous anesthetic that we've used in the past, such as Tilazol or Torpagesic, if the patient had a hard time coming out of a procedure, or if the patient had a heart murmur, anything like that, we would put that under an alert, so that way we're always aware of anything before we sedate them. Also, we have all our notes here, so our subjective, objective assessment, our diagnosis, and our plan. So our technicians would always put our notes here. So for example, if a patient came in for a procedure, we'd ask to make sure that they didn't eat after midnight or so. Any ongoing issues, anything that's changed that's been happening before the procedure, just so that way the doctor is aware of it and we are all aware of it before we sedate them. It also includes all the client information on top too, such as phone number, address, things like that, stuff that's readily available for us to look at. We also have our consent forms that anybody needs to sign before we sedate a patient here in the clinic. So this one right here is an example of our consent form that we have. We have, of course, have them initial for any pre-anesthetic blood work that needs to be done, which is always required for any procedure. If it is a senior patient, we always have them do an extra lab test done that we send out to Antec and IDEX, and then we get results the next day. It's a whole senior profile that we do on them. We also ask if they would like a microchip done today, or unless they have one already, then of course at that point we wouldn't do one. And then at the bottom it says that they've been told everything, they've explained everything to them, they are aware of what's going on today, what the procedure is, and they would just sign date at the bottom. They would give us the best phone number to call after a procedure's done, so that way they know when their pet's ready, and then they can come pick them up later at a specific time. And then of course at the top we'll always have what procedure is being done and the date that it's being done. On the top left hand corner, you can see the patient's name, their age, and their ID number, so that way we always keep track that it's the right patient and the right paperwork for them. At the same time as the consent form, we also show them an estimate for whatever procedure it may be. So here's an example of one that has already been signed for a previous procedure, which was a dental, and the whole dental estimate itself. It's going to be backwards on the screen, but you can kind of get the gist of it. There's always a variance at the bottom, and we include everything that's possible, such as pain meds, antibiotics, and any other blood work and stuff that needs to be done, such as fluids and things like that. And here is a consent form that we normally do for dentals, which is super important. Let's see. So here you can see that signed at the bottom. We have a phone number and also the date. And the reason why the dental one varies is because we can ask them if they would like a referral for a dentist, rather than us doing the extractions for them. For identification of a pet, to help keep track of that we have the right patient, we put some identification collars on them, so that way it has the clinic's name on there, the phone number, and also the patient's name, and we also have what breed they are. So it's around their necks and helps us keep track of having the right patient, because sometimes there will be breeds that are the same and they look exactly the same, but of course they're all different. Also, we have our hospital cage cards. So it has all the patient's information signalment on top, the date, whether they're staying overnight or just for the day, and also circled here you can say what procedure is being done, such as just anal glands or growth removal, dental, x-rays, anything that you can name you can put up there, supplies that they have with them, and also some really great stuff at the bottom is going to be if we need any urine from them, blood work, if they're okay to walk, if you should be aware of them, any aggression that the patient has, it'll be on there, and also whether they're contagious or zoonotic or not. It'll also be on there, so that way we have alerts and we know what's going on, and only specific people can touch them in those cases. If we were to do any lab work on a patient, such as senior ones mentioned before, definitely if they're 10 years or older, we can do some senior blood work on them. So a whole CAM panel, we would do an SDMA test, so early detection kidney disease. So for example, this is a lab form to Antec if we were to do a senior panel. So here is a senior profile, includes the urinalysis and the complete blood cell count, thyroid, and there's a super CAM panel. And then IDEX is separate. So here's an example of IDEX consent form. All the signalment to the patient, that way make sure it matches up with the blood sample and where it's coming from, so our clinic name, and it says what test is on there as well. So our SDMA test and what you need for that test. Another form that's important is the anesthesia form, anesthesia record itself. So here's an example of a blank one that we would do. So of course we have all the signalment on top. The doctor would go through the exam right here and go ahead and write down the patient's weight, heart rate, respiratory temp, skin, musculoskeletal, heart, lungs, digestive system. Also, the pre-surgical risk is right here, so we have our different grades. And we would circle one, and of course the technician looks at them first before the doctor does, so we kind of have a general idea of how the patient's doing. Not only do we have our whole anesthetic form, but we also print out an emergency drug sheet, which comes in really handy for those times that we need to, start to recover, to go into CPR or anything like that. Emergency drugs that we can pull up. Also down here at the bottom, it'll show what time we start our anesthetics, what drugs are given, the amount given, and the routes such as IM, IV, etc. Whether they're intubated and what size it is. Also the surgery start time and end time, so we have two different times that we keep track of, whether an IV catheter is placed or not. Oral exam is done, fluid rate, and of course every 10 minutes we keep track of the vital signs of the patient, such as heart rate, blood pressure. And also at the very bottom you'll see the post-op stats. So we take, at the time that the surgery's ended, we take the final temp, heart rate, respiratory, we check the color of their gums, what time we extubate them, what time they are standing, and any post-op pain that they may have. If there's any complications, we would put at the bottom. Of course, we mark off when their phone call is made to the owner when they're done. And here is an example of a completed form right here. So every 10 minutes we have that here, and then this is when the procedure was completed. And then any extra notes can be added at the bottom, such as any extractions. So this was an example one for a dental. When it comes to finishing an anesthetic procedure, it's always important to go over any discharge instructions with the owner themselves, because they're not really aware of what to look out for. They're glad that the procedure's over with. They're glad their pet's taken care of, but they also there's some at-home care that they need to watch out for as well. So usually if it's a regular spay neuter, it's definitely send home with a collar. For example, if it was a spay or neuter, I would tell the owner to make sure and keep activity level to a minimum, just because if they're, when it comes to puppies, young dogs, super energetic, they love to jump around, jump on and off of things, and that puts them at high risk for the incision site to open up, and then that leads to infection, and then we'd have to go and, basically repair and do the whole thing over again and resuture. And then they would have to be on antibiotics for a while, so we wouldn't want that to happen to the patient. Also, they maybe go home and be groggy for the next 24 hours or so. Sometimes they'll be super energetic here, but as soon as they go home, I tell them that just to be aware that they may just, sleep the rest of the day. Feed them half of a meal tonight, and then the next morning they can continue with their regular meals that they feed. If it was a dental and they got many extractions done, for the next couple of days I would tell them to stick to wet food, just because their gums may be a little tender, especially where any extractions done. They may not be able to chew any hard food, so that would be super important. No running or jumping, or access to stairs sometimes is a main key. Just keeping them in a kennel at times too, if they are getting spayed. Any medications that they will need to go home on. So usually we send home some pain tablets. Pain injections are always given in clinic, so those are important before they wake up. And then of course the owner follows up with pain meds at home. And then at the same evening, if it was a dental, they could start antibiotics that night. So that way all the bacteria that was messed around in their mouth, we don't want any infection to happen. Sutures, we normally absorbable sutures are used, which are super handy, so that way owners do not have to come in. But there are times where some get stuck and they don't absorb all the way into the skin, so we tell owners to keep an eye on that incision site. You want to check for any redness, swelling, any pus that may be showing. Also, sometimes they may get a little itchy and it starts to scab over, so be aware that, make sure that they don't scratch that spot. Even though they have a cone on, they may use their back legs. Also make sure that they're not lethargic, they return to their normal routines, such as drinking water, eating, things like that. If they start to refuse anything, or if they start having vomiting or diarrhea, especially if it lasts for the next 24 hours, 3 days or so, then definitely bring them in, and then we would have to recheck them and do a whole exam and see what needs to be done for the patient. Other than that though, if a spay or neuter came in, we don't generally do follow-up appointments. We can do follow-up appointments when they're non-absorbable sutures. If a client feels more comfortable with us keeping them overnight, we definitely can keep overnight, so that way nothing else happens. If a patient gets a spay or neuter done, I would tell the owner not to bathe them for the next 10 to 12 days, just to let that incision site heal well over time, and we don't want any irritation and any potential infection that could occur from giving a bath. This is Sasha, so I'm going to be demonstrating how to do blood draws. To hold for a blood draw, specifically cephalic, so you'd have their head against your chest, put the leg out, and roll the vein with your thumb, and push the leg out for whoever's doing the blood draw. For doing a jugular blood draw, so you'd have the patient, of course, sternal. They can be sitting. And any collars you can take off as well, so that way you can see the jugular vein here. And you would lift their head up, not too high. Sometimes the person doing the blood draw would not be able to see the jugular, and just depending on what they ask for, chin down, head left or right, you can do that. Also for a saphenous blood draw, so dogs, you would do a lateral saphenous, so use their back leg, push the leg out, kind of hold off that leg too, so that way you can see the vein that's down here. Sometimes those are squiggly veins, so doing a great hold on it will kind of help keep it still there. And then for cats, of course, you would put them in lateral recumbency, and then you would hold off on the leg there, so that way you can get the medial saphenous vein. But of course, normally with dogs we do the lateral, cats you do the medial, so that's why it's held differently. So here we have Oslo. I'm going to demonstrate how to move a patient in and out of the cage. This is a smaller cage since he is a smaller pet. You can put them in the run sometimes, but there's a lot more space, and also you can use that for bigger dogs as well. So for a small cage, of course you're going to open it slowly, make sure they don't jump out. And then you can turn them around and then sort of do like a scoop motion and carry them out like so. And then if you were to put them back in, so put them on there, move their head away from you just in case if they want to try to snap at you. Leave one hand on them, slowly close, and take one hand out, and close it right there. And that's how to move a patient in and out of a cage. When it comes to putting on a dog muzzle, usually it's with an aggressive patient. So luckily Sasha here is pretty nice, but I'm going to go ahead and demonstrate how you would put one on if an aggressive dog were to come by, and how to put a muzzle on properly without, less risk of getting bit. So, of course, you get proper sized muzzles, so this would be a good one for her. A little cushiony, she's a little, her snout's a little shorter than usual, but of course, so you're going to want to come from behind, slowly go over, and slip it on. And then clip it in the back, and tighten it. There you go. Good job. Yeah. Here, let's take it off. Here. So if, for example, Luke here got a surgical procedure done, such as a neuter, then he would go home with an e-collar. So the e-collar, what it does, it prevents them from licking or bothering an incision that is on them. So normally you can measure around them, and usually, as long as their snout doesn't stick out further than the cone itself, then it's good for them, because then they can't reach the incision itself. So we're just going to slide it on here. You want to be careful with the eyes. You're going to test it, make sure it doesn't come off right away without any gauze in the loops. And then you can use some string gauze and put it through each loop and tie it all the way around, and that way it's more security to make sure it doesn't come off.
Done.
This is Luke here. I'm going to go ahead and do a complete physical exam on him. Normally you would do an exam before surgical procedures, or just on a regular visit to the clinic. So today I'm just going to give him a general physical exam. I'm going to go through all the steps, and I'll also give him an ASA grade as if he were to get a surgery done today. You ready, Luke? You ready? So first we'll start off with feeling some lymph nodes, which I do not feel any enlargement, inflammation of the lymph nodes. Of course, we'll check the teeth. You want to go to the very back, especially with those teeth back there on the molars. Come here, you're okay. Incisors, hi. You're doing so good. And at this point, we would do the otoscope, so that way we can check the patient's ears. Stay there, it's gonna tickle.
Good boy, Luke.
Good job. So, hold on. Luke, you're okay. It's a tickle. You're okay. Let me see. Let me see. Let me see. They look normal, no inflammation, no redness going on. A little bit of earwax, but that's okay. Gotta check your other one. Same as the other ear, no redness, no inflammation. See how they react to the light shining on them? Open his eyes, make sure there's no possible ulcers going on. Usually if you have a concern with their eyes, you could do some tear testing or stain or any other test that could help determine if There's no eye discharge going on either, so no possible infection. It's looking good so far. I'll go ahead and listen to his heart and his lungs. Stand up, Luke. Stand up. Alright, so his heart sounds good. Usually if there was a problem with the heart, such as a heart murmur, instead of a good love dub sound, you would hear kind of a swish in between. But his sounds perfect. I also listened to each of his lungs, and they sound great as well. Sometimes there can be some wheezing, crackling sounds within the lungs themselves, but his is perfect, so he's good. Now I'm going to check the rest of him out. Scoot over. He says, I'm sleeping. I'm going to feel their pulses too. Femoral pulse. Still strong. I feel all the lymph nodes, which feel great. Right. I'm going to check under their tail. And last but not least, we can go ahead and get a temperature on our patient here. Good job.
No.
Good job. Almost done. Almost done. Stay. Okay, his temperature is good. It's at 98. That's how you do a physical exam. And for, if he was getting a surgical procedure done, you can give him an ASA grade. So when it comes to anesthetics, a grade that I would give him, I'd say he'd be a grade 1. Nothing going on. He's a really young dog. He's doing good. I'm going to go ahead and do an exam on Magic here. So, of course, when you start off with the exam, you want to check, you want to start from the front, work your way back. So first we'll check the ears. Just get a good look inside, make sure they're not infected. No redness, no inflammation going on. Definitely check their eyes, make sure there's no discharge. We'll go ahead and check the teeth as well. We'll go ahead and check the mouth as well. Hi, you're so good. Check all our lymph nodes. Go ahead, feel the belly, make sure there's nothing hard, no stiffness. You gotta go pee. Yeah. Check under the tail real quick, make sure there's no diarrhea going on. Also, you can check for mats, see if they're grooming themselves well. So here I can tell he definitely has dandruff going on. I'm gonna go ahead and take his temperature as well. Last thing, usually cats do not like this very well. We're gonna go for it. Oh, yeah, pups. I know. I'm sorry. Okay, his temperature is 99.8, which is good. That's totally normal for a cat and dogs as well. So there you go. So we can always add something to their diet to help that. Now I'm going to go ahead and listen to his heart and lungs. Okay, now that I listen to his heart and lungs, his heart rate is really quick, and most likely he's excited or really anxious. And for his heart rate, I got around 184. So I counted it for 15 seconds and multiplied it by 4. And I listened to his lungs as well, both sides. Gotta make sure and get all the lobes. And for his breath, his respiratory rate, I got 32, which he sounds pretty good. He's doing great. He is diabetic, so when it comes to assigning him an ASA grade, I would give him about a grade 2. You know, he can be at risk, but his heart sounds great, his lungs sound great, everything sounds really normal. He's doing good.
Okay.
I'm going to be doing a cephalic blood draw on Miss Sasha here, so she can get her heart rhythm test done for her annual. So put a little bit of alcohol.
No,
You're okay, Miss Sasha. You're okay, darling. You don't need very much. You're okay, Sasha.
You're not Hey, what's that?
No.
You're okay. You're okay.
Good girl. Just one drop. That's
Baby
all you need.
girl.
You're okay. I'll put a pressure bandage on there. Good girl, Sash. Twist that. And here we go.
Okay.
Done. Okay, so today we're gonna go ahead and get a blood sample on little Luke here, and we're gonna draw it from his jugular vein. So what we're gonna do is we're gonna shave his hair.
Be
Put your
brave.
thumb,
Be good boy.
thoracic inlet, and usually you can see the vein pop up. So if you come a little bit closer, you can kind of see it pop up. So put my thumb, and it'll fill up there. And it's gonna be bevel up.
Good boy.
So still there. Good job, Luke. Good jobs. And draw back.
Oh, good boy.
And hold off there. So this, I'm going to demonstrate how to do a lateral saphenous blood draw. And also for big dogs, it's super nice sometimes because they have a larger vein back here. So of course, Robin here is holding off for me. I'm going to put alcohol where the vein runs right here.
You're okay.
And I have a small syringe,
Okay.
the small needle,
Good
just
boy.
because it is a tiny vein.
No, no.
I'm just going to need a small amount. Sometimes these can roll a lot, so it's good to keep them stable. And there you go.
Good boy.
And that's it. I will be demonstrating how to draw blood from a cephalic vein on a cat. So I'm going to do that right now. Oh, you're so sleepy. You want to wet their hair with alcohol so you can see the vein better. You want to feel for it. And then Dr. Karen is holding off the vein for me. And there we go. I'm going to be doing a jugular blood draw on this cat here. So that way we could go ahead and do a senior assessment. So I've already shaved the area. Now I'm just feeling for the vein. I'm occluding it by putting my thumb on the thoracic inlet. Robin, hold on. I'm going to get blood today for a phenylleukemia and AIDS test. I'm going to draw from the medial saphenous leg. So, Margaret, if you want to come closer so I can see. And then, let me part the hair so I can see the vein well. You're okay. Okay, so do you mind tapping this little one's head? She's a little baby. She's scared.
Hi, babies.
So make sure to go bevel up.
Oh,
Oh
no,
my
no.
goodness. You're okay.
Oh, no, 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 no,
You're okay. Oh, I know.
We're almost done. I know. Oh, it's a baby.
You're okay. I know. I don't need very much. Before any surgical procedure, a patient should go through and get minimum databases on them to make sure they are able to go through and handle the anesthetic procedure itself. So you can start off with ALT, BUN, also a total protein, or you can get a specific gravity of the urine, and also you can do a blood glucose check, or and you can do a packed cell volume. So packed cell volume is the percentage of red blood cells. You usually use hematocrit tubes, and it's a super simple test. You can also do BUN, which helps us to get a good look at the kidneys. Also, the urine-specific gravity can help us determine whether kidneys are functioning or not, and kind of gives us a look at the percentage of the kidneys that are functioning. Also, the color of the urine too will give us a good look whether they're filtering correctly or not. Also, with ALT, we can get a good look at liver function. And the blood glucose, of course, is regular glucose. Make sure they are able to go through an anesthetic procedure with all of these values. Even if the one thing was off, for example, blood glucose, if that was not regulated, then we would start the patient on insulin, not go through with the procedure itself, and then have them come back until they're officially regulated on their insulin. Also, with the kidneys, sometimes they're just not functioning well at all. They're just only using a portion of their kidneys. Sometimes we just don't recommend any anesthetic procedure for them. Also, sometimes if during an exam, if their heart rate for whatever reason is not normal, if their heart doesn't sound normal, you can do an ECG before procedure until you find out what is going on with the patient's heart. If you can always do a full blood panel on a patient, and if they just overall do not look healthy enough for an anesthetic procedure, you can get them on supportive meds, get them going again, and you can always recheck blood work later if it comes to a point where they're perfectly healthy. I wouldn't say perfectly healthy, but if they're a lot healthier than they were before, you can always proceed with the previously scheduled procedure. If for whatever reason a patient isn't breathing right as well, or if you want to take a good look at the heart to see if they have an enlarged heart or if there's fluid in the lungs, you can always take an x-ray. Make sure you are able to continue through with the procedure. Before an anesthetic procedure is done, we always make sure we're using the proper sedatives that are needed for the procedure itself. Of course, us technicians do not select these. The doctors always do, but they tell us what to draw up and what to be given to the patient. So, for example, our spay today, we pre-sedated her with torbagesic, a mixture of torbagesic and acepromazine. So, torbagesic, also known as butorphanol, it can act as a painkiller for them, so that way they're not in pain right away when they wake up. But then we also give an additional injection prior to them waking up from a procedure. So they also have that butorphanol and the carprofen injection as well. Or if it was a cat, we would give Symbadol. And then for induction, especially for the larger animals, I'd say around 40 pounds and up, we give Tilazol. That way they can go down a lot quicker. If we were to induce them with a mask, sometimes they can thrash around, go through the excited phase, and we don't want to harm ourselves, and we don't want to harm the pet, and we don't want to be wrestling with them. So the Tilazol gives them a nice induction, and then you can intubate right away. And then afterwards, of course, as mentioned before, we give a pain injection before they wake up, so that way it acts right away. They don't feel pain instantly. And then we use lidocaine around the incision site itself, so that way the patient doesn't feel the need to right away start itching or bothering the incision line, so that way they have a healthy recovery. I'm going to do a drug log. Usually with drug log, you're going to do it for any controlled substances that are used on the patient prior to surgery or any sedation procedure. So here is our drug log. You could do the date, owner and the chart number of the patient, pet's name, drug that is given, the strength of it, container number of the bottle, the amount that was given, mils or tabs, and our initials.
So of course, we'll put today's date. Owner's name is going to be Nelda Shipley. And the patient's chart number is going to be 11378. Pet's name is Suzette. And how the drug given is torbagesic. Container number 102, the amount that was given. And mLs, and then our initials. And then our actual drug book, our manager will go and write all of this information within our drug book, and then she'll come back and have us initial it, so that way we have a double check system going on, so that way no drugs are missed and no variances occur.
I'm going to be explaining our scavenging system. So here is one of our anesthetic machines, and I will go through each part. So of course our oxygen tanks are actually in a closet in our treatment area. This is the surgery room itself. So everything is separate from the treatment room. This is where our oxygen comes through, and it's hooked up. You hook it up before every procedure, and you want to leave it unhooked when you leave. Of course, here is our vaporizer for our SIVO, and it goes from 0 all the way to 8. Usually when you're inducting a patient with the gas mask, so you would use these for really small pets, or you can use the larger ones for larger animals, and you want to choose whatever size works best. And you can start off at 8, and then for maintenance you can always put them at 4. And then here is the level of SIVO that is in the vaporizer. So it flows through. And then here is our oxygen. Here's our meter to keep track of how much oxygen is being put in, and it does measure in liters per minute as well. And here's our flush valve for the oxygen, so if we needed to fill up our bag so that we can give a breath to our patient, we could just hit this, fill it up, and then the bag will fill up itself. But we don't want to waste any, so I stop there. And then of course the oxygen will continue to flow. And then this is our pop-off valve back here. So there is a knob that you can physically rotate it to that way it can close off the valve for you. Or you can use the quick button one, so that way you don't forget to open the pop-off valve, which if you were to forget, then it would build up pressure in the patient's chest and could lead to death. Here's our soda sorb. So what it does is it absorbs all of the carbon dioxide that is passing through the system. So of course, what that means is when we are using our Y pieces, this active system, what it does, this is the inhalation, and there's when the patient exhales, then it goes through here and absorbs any carbon dioxide and any waste that is in the system. It goes down into our air canisters. So our air canister, if it's currently at 200 grams before it was used. So if I were to measure it right now and it says 220 grams, then it would need to be changed. But since we change it weekly, we never really reach that amount. So that weekly maintenance helps us minimize any harm done or overuse of our Sodasorb or the air canisters. For the Sodasorb, you replace it weekly, or sometimes it'll start to turn purple and that'll show the absorption, kind of give you a sign of when it needs to be changed. Never really gets purple because we change it weekly, which is good because we're not absorbing too much. So not only do you have the active, but you also have the passive system. So usually this is commonly used in cats or really small, puppies. It bypasses the filtering system, so it just relies on the oxygen to push the anesthetic and to the patient, so that way they can be sedated or be induced. And then, so you can see here, this is where you would open and close rather than a pop-off valve. And you still have your bag on the bottom, so you don't have an inspiratory or expiratory passing system. You can also use a chamber. So what this is used for, if you get an aggressive cat for whatever reason, now you're not able to touch them, you can just put them in here and close the box, and then there is a hole right here at the end, so that way we can put, so this would be hooked up to the anesthesia machine, of course, and then this end would go into here. And then there's no waste into our room. It's trapped the hole, so that way all the anesthetic gas will go in here and eventually induce the patient that is in the chamber itself. And it's an easier or safer way to induce an aggressive cat or small dogs, but you can't do it for bigger dogs, of course. When it comes to the anesthesia machine, you can change the sizes of the anesthetic bags. So this one right here is one size that we would use for a larger dog. I'd say about 50 pounds or so. But if you were to get a puppy or a cat, then of course you would switch over to the smaller ones, such as a ½ liter or 1 liter. I'm going to be performing a leak test on our anesthesia machine. So here's one of them. What you're going to do is, of course, hook up to this scavenging system. So here we have our oxygen line hooked up. And then, of course, you're going to grab your tube. So here is a small tube, and we have a 1 liter bag. Make sure it's deflated, everything's out. Now what you're going to do is go ahead and close the pop-off valve, which is located here. So go ahead and twist that all the way down. Now what you're going to do is you can use your thumb to cover the hole, or you can use the palm of your hand. So I'm going to hold it like such. Now I'm going to turn the oxygen on, let it fill up, and you can read it here. It'll go up all the way to the 20. Lower that down. And it should stay there. So give it about 5 seconds or so. It should stay put. If you start to see it lower down, then there's a leak somewhere. So here I have it in my palm, and it's staying pretty steady. So there's no leak in this anesthesia machine, and it's perfect. It's good to go. You can use it for a surgical procedure. Make sure and always open the pop-off valve, turn off the oxygen, deflate anything, then go ahead and unhook your anesthesia machine. When it comes to monitoring a patient, there are multiple things to help you monitor the heart, their pulse, the percentage of oxygen inside the blood, also their respiratory rate and their breaths. There's all kinds of parameters to keep track of. So first, start off SpO2, percentage of oxygen within the blood stream. You can put this one on the tongue, or you can do it on the ear or on the toe, just any thin piece of skin that's pink and could detect the pulse as well. Next would be the esophageal stethoscope. So normally they would be hooked up to be put into your ears, just like a normal stethoscope would be, but this one is actually hooked up straight to the monitor. It detects the heart rate, and also it keeps track of their temperature as well. Normally you could have just a separate probe for it, or you could just monitor the temperature yourself with your own thermometer, but this one comes in really handy because then it's internal and as deep as the esophageal stethoscope would normally go. We'll go ahead and do our esophageal stethoscope. So normally these could be hooked up like a regular stethoscope, but ours is actually hooked up to the monitor, so it automatically records the heart rate for us, and we don't have to listen for it. So of course it's going to go into the esophagus. And then we'll hook up our SpO2, and this one goes on the tongue. And then you can even put dry gauze with some water to keep the tongue moistened. So you want to watch the monitor, make sure she gets a steady rate and a good pattern to make sure that's where your esophageal stethoscope needs to be. The esophagus, you can do gastric intubation. So what that is getting a tube similar to this. Sometimes they're bigger or smaller. You pass through the esophagus all the way into the patient's stomach. So if we were doing a GGV procedure, then we can pump the stomach or suck anything out of the stomach as well. And usually esophageal stethoscopes, it gives just a more accurate reading of the patient's heart rate, just because it is a lot closer to it. Next, we'll go over the ECG. So of course, there's multiple leads to put on. There's 4 different ones. And of course, that monitors the heart itself. The pattern will come up on the monitor screen. You can keep track of the P, QRS, T waves, and also you can notice any arrhythmias or skipped heartbeats, just to show the regularity or irregularity of the heart rate. When it comes to endotracheal tubes, there are different ways to test them before they are used. So you can easily inflate the cuff on the endotracheal tube, leave it there, let it sit, watch to see if the cuff deflates after a while. You can also test it out within the water, and I will go ahead and demonstrate that. So with the endotracheal tube, you can inflate the cuff and blow it up to see if it will stay inflated. So just leave it there for a bit, test it out. You can feel it, see if it'll deflate or not. And if not, which is good. Bye! Also, you can put it in some water so you can test out to see if there's any bubbles once you're inflating the cuff, and then that'll determine if there's any holes within the endotracheal cuff. So blow it up, check for any bubbles that come out, and if there's none, then your cuff is good to go. Respiratory monitor. So usually a respiratory monitor can be hooked up at the end of the endotracheal tube. We currently do not have one that is working at the time. So normally the respiratory monitor would be hooked up and also do monitor the breaths of the patient as well. But we have a breathe-safe monitor which still beeps with every breath that the patient takes, so we can listen to it ourselves, or if we're not in the way of the surgery, we can look at their chest, feel their breaths. But of course we can rely on this breathe-safe monitor temporarily. But normally a respiratory monitor would be placed at the end of the endotracheal tube, right where the anesthetic gas flows through. Blood pressure. So normally blood pressure cuff looks like this. Wrap it around the patient's leg, and then there's a sensor in there that detects when the blood flow starts to flow back into the arteries. So it'll cut off circulation, and then it'll sense when the blood starts to flow, and so that'll calculate the blood pressure for the patient, so you can help keep track whether if their blood is flowing correctly, and if it slows down, if it lowers, then they could be too deep into anesthesia. And for thermometers, as mentioned before, you can use your own thermometer for their temperature, or for a patient's temperature during a surgical procedure, you could use a regular thermometer, or there is a specific probe that can be used that can be placed into the patient's rectum, or as for example ours, it is integrated with our esophageal stethoscope as well. Okay, go for it.
Hi, my name is Karen Smearmall, and I'm the owner and veterinarian of Sanford Oaks Animal Clinic, and I work with Marissa Aguilera. And
I'm going to be doing an IV catheter in cephalic vein. So I'm going to go ahead and show you the leg where I'm going to put my catheter. And get rid of all this hair. You want to do 3 and 3 alcohol, 3 betadine, 3 alcohol. We're still going to do the target pattern the same as you would for our surgery. Once you go dirty, throw it away. Once you see a flash, go ahead and advance. And I'll hold off here. It'll slow down the blood from flowing. Now we're going to go ahead and flush the catheter and make sure it's still patent. And make sure it doesn't blow up around the vein. Make sure it flows through. go ahead for extra support. Put your vet wrap on there, not tightly, just enough to keep it stable. There you go. I'll be demonstrating a lateral saphenous catheter.
So, my materials, I'm going to go ahead and put these.
Okay, now I've shaved the legs, I'm going to go ahead and prep it. So we're going to do 3 scrubs of each. Betadine and alcohol. You want to do a target pattern. Once you touch dirty, throw it away.
There's alternating between the two. Good girl, girl. Good girl. Good girl, girl. I know, it's a good girl. Now you can dry off just a little bit with some dry off so that way the tape can stick. I know, honey. It's whiny. Thank you, I'm a sweetheart. Let it dry off while it's dry.
Let's try one more time.
There it is.
And you advance your catheter, take it out, right away put your plug in. Before that happens. Put this to the side. I had dry gauze. Where'd it go?
I don't know.
Okay. And continue with your tape, just like a regular cephalic catheter.
Sticky side up. Go around. Use some sticky side down. Little slit there to stabilize the catheter itself.
You want to make sure it's patent, so hold off. Put your heparin flush. You want to make sure and watch it doesn't blow around the thing. Once that's done, you can add an extra piece of tape, twist it, put it underneath, and that kind of locks it into place. Especially with the back leg catheters, it can be hard to keep them in. Then you get your vet wrap. And this is the last step to stabilize your catheter. You don't want to do a tight wrap, just gently. And put that flap up. And there's lateral saphenous catheter. This is Magic, and he needs his insulin this morning, so I'm going to go ahead and do a subcutaneous injection on him for his insulin. He's already eaten, so I'm going to open this up. I'm going to make my little tent. I'm going to go in the back, parallel to his skin. And there we go. All done. He's gotten his injection. You stay there. Stay. Here we have Colbert. He's actually getting his Adequan injection today for arthritis. And this every injection is going to go in the muscle. So I'm going to go ahead and demonstrate that. So of course you're going to feel around for a good spot for the injection. You don't want to be in the back because then you can hit a nerve and then they can have trouble walking later. So always try to get a good spot. You're going to go straight in, pull back, and then you're okay. Good job, Colbert. There you go. And that's now your injection. Oh. I'm going to go ahead and give an IV injection. I'm going to be giving it in the medial saphenous vein.
So you want to clip the hair so you can see your vein better. And of course we're going to put alcohol on so we can see more.
So now the vein will really pop out for us. So you want to pull back till you get a flash and slowly advance.
Sometimes you can see if it's bubbling or not around the skin. See where you're giving it subcutaneous or IV.
I'm going to go ahead and induce our spay for today. So here I have Tilzol, which is pretty quick. You don't have to do it in increments. But still give it slowly. Now we'll go ahead and flush it as well. Tongue out, give me a better look. Back straight down. Good. Immediately hook up to your oxygen. Turn on our vaporizer. And then we'll tie off as well.
So it's tight, you don't want to cut off this part of it, so you put the cup. Tie it around the nozzle. And we'll go ahead. Put air to inflate the cup as well. It's pretty loose, so we'll put 2 cc's at first. And then we can go ahead and close off our valve and test it. Wonderful. There's a lot of air flowing through it more.
Perfect. We don't hear anything, so we'll hook up our breathe safe monitor. We'll go ahead and turn her over so that way we can prep her for our procedure. Now go ahead and move her eyes.
Okay, sorry. Let me grab a pen real quick.
And we're going to check her bladder, make sure she doesn't have one. She might pee before she came, so it might probably not. And still can squeeze it, make sure nothing comes out. So that way we're getting away during her spay. Now we're going to go ahead and shave. Use the 40 blade. Start pretty much at the xiphoid down. prepping, you want to have a clean hand and a dirty hand. The clean hand is the one that you're going to be using to grab the gauze, and the dirty hand is the one that you're going to be using to scrub. So I'll go ahead and start with the betadine. So put it to my dirty hand, start from the center, target pattern, just work your way out. Once you reach the edges, then it's no longer in use, and you toss it. You can squeeze out some excess alcohol from the gauze because you do not want to make your patient too cold.
Ready?
So I'm going to turn off the anesthetic machine, and we'll transfer her with the RV. Go ahead and tie her up again.
You want to remove the,
The blue one? Yeah.
Yeah.
We can remove it.
right?
Okay, there you go, guys.
Is your arm full? Could you hand me the chirping thing? Oh, it's right here. Just kidding. You know, the breathe safe. You know, I know what it's called. It's
I call it the cricket.
the cricket. I like it.
Until you get the back one.
Did you go to the side?
No, yeah, I just went to this side, yeah. Right down there. Actually, we'll scoot her up more. So then she'll
Let's
pop the
raise
budget.
this table some too.
Yeah.
For sure.
I'll raise it on my side.
Yeah.
Here, that one.
Yeah.
Lift her up. Go
Yeah, that's
ahead
good.
and raise our table. So the doctor is not having to lean over so much.
Let's get her picked up.
So currently we're in the process of a canine spay, and she's doing great so far. She's been doing wonderfully. Her heart rate here I have is at 94, 96, goes back and forth, mainly 96. SpO2 is at 100, which is perfect. Our CO2 hasn't been working, so we haven't used it, but we do count the respiratory rate ourselves as well. So I've already got that down, and that's at 12. I'll go ahead and put her temperature, which is 99.9, which is also great. And then her capillary refill time, we'll go ahead and check her gums. So that would be less than 2. And we'll go ahead and write the rest onto our anesthesia log. Go ahead and give her a breath. So with this log, breathe safe monitor is on, heart rate, and then for blood pressure, we're using our pet map, so I'll go ahead and use this. So 104 over 59, 78.30. And it also gives us our heart rate here, so you can kind of match with the monitor as well. There you go. This is Doug here. So he's going to be my doll as if I were to pretend like I'm performing CPR. He is kind of short, so he would be considered a small dog, so he could easily lay on his side, lateral recumbency, and we can do compressions on his chest like so. Small compressions. If he were a bigger dog, it's easiest to put them on their back, especially if they're deep chested. You want to push down on the ribs, and then that way you can easily give compressions to the chest. Because they're so deep chested, when they're on their side, it is not very effective. Also, before when a patient does need CPR, you want to make sure their airway is clear. So look into their mouth, make sure there's nothing lodged in the back of their throat. If there is something, of course, take it out. If there's not, then you could intubate them right away, or you can use an ambu bag to give them breaths, or you can do manual ventilation with your mouth and your hand to the patient's face. Most proper thing you can do is intubation, so that way you can use the anesthetic machine to give gas to the patient right away, and then you can manually give them breaths in the reservoir bag. As well, you can start to do your compressions of the chest. Usually you want to do 100 to 120 beats per minute, so that's around 2 compressions per second. You can do this for about 2 minutes or so and switch out with somebody next to you, because you have to do it so rapidly you don't want to tire out, and you want to keep it going. So one person can be in control of giving the breaths, another person is in charge of compressions, always having an extra person handy, and then somebody else could be hooking up the patient to an ECG and other monitoring equipment, so that way we can monitor the heart rate, make sure when it comes back if we ever lose it. And when it comes to intubation, you want to do around 10 breaths per minute, which would be a good rate for oxygen and breaths. If you were to do manual ventilation, so if you're going to do your mouth to mouth or mouth to hand, then you would want to do, you would want to do 2 breaths after every 30 compressions or so. Say if you're by yourself, there's nobody else to handle the anesthetic machine, and then you would do 30 compressions, or 30 compressions or on their side. In this case, Doug is small, so we would do the chest and the side, and then you would do your 2 breaths, and then go back to the compressions. I'm going to be demonstrating how to scrub in for a surgery. So of course the most important part is the scrub of the hands, and then keeping everything sterile. So I already have my hat and my mask on, so I'm going to come over here, and first you're going to start off with a general hand wash. Really want to get under the nails. You can sometimes use a nail pick beforehand. So really good hand wash beforehand. Then comes the actual scrubbing part. So here you can get one of the brushes. Scoot this back, and you can put some onto the scrubber itself. Just kind of pump it onto there. And this one is kind of thick, so it takes a while. Now, when you start scrubbing, you want to imagine every finger has a quadrant, so, you know, you're going to do this side, this side, this side, this side, so on and so forth on each finger. Then you want to go to your palm and the back of your hand, and then the last part will be the elbow. And then you go on to the other hand as well. So, first we'll start with this one.
We can do about 20 strokes each side, so to speak.
From this point, when you rinse off, you want to make sure the water runs down. So any organisms that are on your hand, it just goes straight down and into the sink. If you go the opposite direction, then you just circulate it all over your hands again. So you want to keep them up to the fingertips, and all the way down, out, the hand, each side, and all the way out. And then you can turn it off. And then you want to come over here, grab your towel, shake it off. When it comes to wiping it, the same as well. You want to follow through. You never want to come back the other direction, because then whatever you just wiped off, you just put it back onto your arm. So fingertips down, one side, move that around a little bit, and then the other side of the hand, move it down, then the other side of the towel, you're going to come back, go down, move that around, go down. So then you can just drop that. And now you're going to grab your gown. Go ahead and put that on. Then whoever is the assistant can come and tie you from the back. And this part is when you put on your gloves. You don't want to put your hands out. You're going to need to pinch the gloves through the gown itself. So go ahead and come over here. Grab this first one. Remember, everything is sterile, so don't touch anything else. Sometimes it can be tricky. Generally get that on, you can perfect it later, but just so you have enough to grip onto the other glove.
So now with this one, you can actually go ahead and touch the other glove. Put your nose underneath. With this one, pry it open. Put your hand through.
You never want to pull just the gown by itself because there's potential of it being removed and then you're no longer sterile. And now it's just fixing all the gloves. We're good, and then once somebody ties you, then you're good to go. I will be demonstrating how to set up, I will be demonstrating how to prepare the instruments for a surgical procedure. So, of course, before you set up any instruments, you want sterile gloves on, and you also want a sterile gown. And when you open a pack, you want to open it, you don't want to reach over the instruments because then any organisms that are on you could possibly drop down onto the instruments and then it goes into the patient. So go ahead and demonstrate it. So first, when you open it up, you'll break the seal. You open up one direction, unroll, and then the tab you'll be able to pull away. You put them on the side, pull away as well. And then of course you don't want to reach over, so you'll pull over. And then from that point, you can go ahead and just gently open the pack. Just unroll it. And you'd be sterile at this point, so you don't want to reach across again, so move over to each side. Slowly. So then all the instruments would be there. And then at this point you can be able to move the drapes to the side, move any gauze to the side, spread out all the instruments. Here's our strip to know that it is sterile. And then you would drop any blade or suture that you would have prepared for the surgery. So you drop them onto to the platform, and then you would move the cart to where the doctor would place it ready for the surgery. I'm going to go ahead and drape this patient as if she was going to surgery. So of course we have our pre-cut drape. And of course we need to make a hole for the patient, make sure it touches nothing else. It's laid out, and then you only want to touch the outside at this point. Just center it to where the doctor would need it for the procedure. So I've already put my sterile gown and gloves on, so I'm going to go ahead and help Dr. Karen with blotting while she's closing up for our spay. So just let me know where you need me to blot. There. So just going to touch very little. Away. And then she can continue with her spay, and then I'll go ahead and hand her an instrument as well. So I'm going to place this down over here, and make sure it is unhinged, so that way she can use it right away, so that way she can continue with her suture. So if I were to pass a scalpel blade to Dr. Karen for a procedure, so you want to make sure the blade is down so that way it's not facing towards your palm, so that way you don't cut yourself, and then of course you're going to hand it towards the handle part towards the doctor, so that way she doesn't cut herself either. So if she needed it, just have to pass it to her. There's an arch on my hand, she would grab it, and then she can go ahead and proceed to use it for her surgery. So of course what you're going to need is your holder itself. You're going to need your blade, which is very sharp, so be careful to never touch the side of it, because then you could do some harm to yourself. And you can also use some forceps to help you load the blade onto the holder itself, so that way you can avoid messing with your hands and cutting yourself even more. So, what you need to do is pick up the blade, lock it in with the forceps. So on here you can see there's two sides to it. So there's the locking, it'll lock onto here, and then there's a little ridge down here which is where it slides onto. So what you're going to do is move it out the way of the part that you need, slide it in, and then so there it's loaded onto these to the holder itself. So there's a scalpel blade already. It's locked in, and it slides down, so it'll lock it into the ridges here. So again, take precaution, use forceps, especially when taking it off. So now to take it off, you're gonna try to get forceps under here, slide it down, and flick off. So now I've separated it from the holder and the blade itself, and then of course you'll dispose of it into the sharps container. During a surgical procedure, you want to make sure it maintains sterility when you're the assistant that is scrubbed in. So you can always clasp your hands like this to help you make sure that you never touch anything else. You don't feel the urge to. Anything from the waist up is considered sterile, waist down is considered non-sterile. So if something were to fall anywhere below your waist, then it's no longer good for use in the surgery. So you would have to replace it with another sterilized piece of equipment, or you can do a flash sterilization. So if an instrument fell on the floor and the doctor really needed it, you could do a flash sterilization, or you can easily, if you have an extra one handy that has been sterilized already, you can instantly grab that and give that to the doctor. If for whatever reason somebody were to come and touch you or the doctor and they're no longer sterile, then at that point that person would have to completely get out of the gown and the gloves and scrub back in. So a whole new set. If gloves were to become punctured or torn, or they're just really dirty, the doctor or the assistant could put some gloves over the old ones, sterilely of course, or you could just take them off so the assistant can go and help the doctor remove by pulling the cuff with the glove, so that way they're able to clasp onto it again with the gown, and then they can put a new set of gloves on, which is the most recommended option. So it's always important to have extra tools handy, so that way in the event that one instrument does drop on the floor, you have one readily available. Go for it.
Hi there, this is Dr. Karen Smirmal from Sanford Oaks, and I just wanted to verify that Marissa has been doing, and I've seen her help assist and do the prep work for canine neuters, for feline neuters and feline space for the last 2 years.
I'm going to go ahead and clean up our surgery suite after our surgery that was just done. So I'm going to demonstrate how to properly do that. Of course, you're going to need a disinfectant, and the one that we use is Rescue. So sometimes you can leave it on there for 5 minutes and clean up afterwards. Of course, you'll need to sweep and mop the whole surgery suite as well, and clean any monitoring equipment that was used, like an esophageal stethoscope. You need to wipe it with alcohol and get it prepped for the next patient. Of course, you'll wipe down the tray that holds the instruments, which is where the phone's currently at. There's everything clean. And then you want to go ahead and wipe the bottom here. Surgery room is ready for the next procedure. We just used some instruments for display, so I'm going to go ahead and record myself cleaning the instruments and making a pack for the next surgery. So there's all our instruments that are sitting and soaking in chlorhexidine scrub, which is diluted. So there's a hint of blue in there, and then of course we'll get our metal brush here so we can scrub all the instruments off. So we'll go through one by one, taking any blood clots off of these instruments here. You're gonna make sure and get all the ridges, especially with forceps. There's all those ridges located on the inside. And then you also want to make sure and get the handle of the instrument as well, because the doctor might have had bloody gloves and then they were holding on to the instrument themselves and could get on there. So it's not just at the tip of the instrument. So now that I've scrubbed all the instruments, I'm going to go ahead and put them into the ultrasonic cleaner. And usually you can leave them in there for about 3 to 4 minutes or so. And you never want to leave them clamped. You want to do it unclamped. So. So now we've finished the ultrasonic cleaner, and now I'm going to go ahead and place them into the instrument milk. And what the instrument milk does is it helps prevent rusting of the instruments. So once they're soaked in there, it'll give a nice lubrication on top of the instrument itself, so that way they do not rust, especially when sitting in packs. So we'll leave them soaking in there for a while as well. Okay, so now the instruments have sat in the instrument milk, and I'm going to take them out, place them, separate them all on the towel here. I'm going to leave them open like so, laid out. And now you're going to pat them dry. Make sure they're completely dry before placing them inside. So here I've got 2 drapes, and I also have gauze inside here. And then we will start separating the instruments by size, and then we can place them in the entire pack by itself all together. Okay, I've separated all our instruments out according to size and the instrument that it is. I have my drapes here, and I have my gauze. So we're going to use the spade hook to help us keep them all in line. I'm going to lay out all the instruments on the bottom of the pack. Lay them out like so. So that way whenever the doctor opens the pack, they're all perfectly laid out. Now I'm going to put the drapes on top, and then we will put the gauze on top as well. We'll put our spay hook and our forceps and blade holder here, right next to the gauze. And then we will begin wrapping our pack. So make sure it's at an angle so that way you can go corner to corner. Make sure the whole field is clean. So first we'll do one corner, and when you're folding you want to make sure and leave little flaps so it's easier for the person to open up the pack without breaking sterility. So there's one, it left a little flap here, easier for them to open. And this closer. You want to make it as tight as you can as well. So here's the next corner to the right. Made a little flap. Here's the next side. It's easy for them to lift on this side. You want to fold that in, scoot everything towards the middle, and then you're going to fold the outer pack the same exact way. So you want to make the flaps easier for the person to open the pack itself. So there's a flap there. This out, fold this side in, making a little flap here, easier for them to pull. And then for the last one, rather than making a flap, you're gonna tuck it in. And you're gonna want to leave a little tab here so that way the person can just easily pull it and open it. And then you will go ahead and grab some Scotch tape and place it here to hold it. And then you're gonna get your steam indicator tape in just a small piece because it is expensive. So once it is autoclaved, these lines will turn a darker color. For example, they will change colors just like that. And then you're gonna want to label the pack itself. So this one is our blue surgery pack. Initial it and put the date of when it was done. And then you can put it in the autoclave. I will be demonstrating how to wrap a pack for a surgical gown. So when it comes to wrapping a gown, of course, you're gonna need to get all the items that are needed for the pack. So here we have our sterile strip. We're also gonna get our tape and our hand scrubs and towel. When it comes to the gown, you want to put it to where it's easy for the doctor to put on right away, or technician, whomever will be using it. So you will combine the top half together, fold it in half, and go ahead and lay it out. Fold it perfectly in half. Then you will bring the sleeve over, line it up to the edge, and then you'll slowly fold line it all up in accordion, fold it along the way. So flatten it out, make sure everything's staying where it needs to be still. So one side's done, and we flip over. Also, when doing the gown pack, you can double check, make sure it's clean before the next use. Sometimes there can be blood stains that need to be wiped off, or it just needs to be cleaned in general, put through the wash. So once again, put the sleeve to line up in the back. And you want to make sure to leave that one corner there, so that way the doctor can easily just pick it up, or the technician, whoever uses it. Just fold it like so, flatten it out. So starting from the bottom of the gown, you're gonna fold it, accordion, and then at the top you'll have that point for the person to just pull it up, so that way they don't have to fumble around with it because it is sterile. So you'll put this at the center of the pack. Next you will put the towel on top, and then the hand scrubbers on top. So first though, you have to put it in order of use. So these will be used first, then to dry the hands, and then of course the gowning. So when it comes to actually wrapping the pack, you want to make sure and leave tabs for whomever is using it to easily unfold. So for example, here's a tab here that they can just easily pull up. And you want to wrap it as tightly as you can. Smooth it out. So fold one side, next side in. Again, a tab. Another tab here. And the last one, tab on top. And then continue with the outside wrap. Keep it as tight. Continue with the tabs as well. Tab there. Off tab here. Go ahead and tuck that in there. And then there's still a tab here for the person to go ahead and just pull it open easily. So now what you'll do, you'll go ahead and put a piece of regular tape to hold it together. And you can write what the pack is. So here is the surgery gown pack, initials, and date of time of pack. So today's the 3rd. And then you're gonna get your steam indicator tape. You don't want to use too much of it. It can be pricey, and you just put that anywhere there. So that way whenever it is autoclaved, it will change a different color, like so. So there's the way it looks now, and here's the way it would look later. Here is the autoclave that we use in our clinic. There are multiple settings when it comes to this one. There's unwrapped instruments, pouches, liquids, or packs. Packs would be just any general surgery pack. Pouches would be clear ones that you can use for smaller surgeries, simple ones that do not require sterility. Any unwrapped instruments, they could be dental instruments. When it comes to putting pouches in, you want them to be able to breathe. So these are right next to each other. There's space for them to breathe on each side, and nothing else on the bottom. It's just one layer. So that's a good way to space them out. Also, before you run any cycle, you want to check the amount of distilled water in the autoclave. You want to make sure it's in the green, a good amount into the green, not just right to the line. So that way you have enough for the system to use, or else it won't properly sterilize. When the cycle is done, it will tell you when the door is open and how much time is needed for it to cool down. Also, usually the pressure is normally between 25 to 31, and the temperature usually reaches to 250 degrees, so that way you can do proper sterility. Weekly maintenance on the autoclave, you can replace this distilled water and then get the cleaner to go ahead and briefly wipe out the inside and the metal plate as well. Monthly maintenance on an autoclave requires a full cycle cleanse. So what that means is using a cleaner, you put a whole gallon of distilled water, flush it through the system, do a few cycles with it. Also, you do a spore test at the end of it, so that way you can check if your autoclave for whatever reason isn't sterilizing properly, then the company would let us know, because we do send off the test to a separate company. When it comes to the monthly maintenance, usually we can disassemble everything. You can take all of this out of the autoclave, and then there's the filter at the bottom that you can clean out as well. So that way you get a full deep clean of the autoclave, and it's good for a month. You do that monthly. Okay, so Layla here had her toe amputated about 12 days ago. So now it's time for her suture and her staple removal. I was looking at it this morning, and there's no redness, irritation, no swelling, no pus coming out from the sutures. So it looks like the skin is healing pretty well. So now what I'm going to go ahead is start her removal of the sutures. So we're going to go in and get the hook right underneath the suture. So this one's pretty loose, so I'll get that one. Pull a little bit. Go on to the next one. Good girl, Layla. Good girl. It's another. Let's see. Good job, babies. Good jobs. Just quite a few. Wrong way. There's one more there. May have to get the staple out first before I get this one. So let me go ahead and get the staple remover. We're gonna hook under here. Just clamp it. There's one. Good job. Good job, Layla. Let's get another. You're okay. Good job. Hold on. There's one more. I want two more. Last staple. Now let's get that last suture out. So her skin is scabbing over it, so sometimes it can be hard, but there we go. Pull that last one out. Double check it. There may be some bleeding, which is totally normal, just because you are irritating the skin again. But as long as there's no pus coming out and there's no sign of infection, then you're good to go. And that's your suture and staple removal.